Hi, welcome to Domain 2, Reimbursement Methodologies, in preparation for sitting for the Certified Coding Associate exam. So what exactly is all of this healthcare? You notice that sometimes it's medical care, sometimes it's healthcare. I thought I should start off by explaining the difference, okay? And it's not really it's like a formula. Medical care is care that is designed to diagnose and treat illness or injury. Preventive care, like your flu shot, that is care. Those are services and procedures designed to keep a healthy patient healthy. And when you put both of those together, you get health care. So now you know the difference between health care and medical care. That also helps you with the difference between electronic health records and electronic medical records. Ooh, all right. So let's talk on who is involved in this whole process of health care delivery. And we essentially have three participants in this healthcare process. The physician or the healthcare provider is essentially the first party. The patient, the person seeking services or care, is the second party. And the insurance carrier who is paying for this delightful little time together and encounter between physician and patient is the third party. Ergo, why we call them third-party payers. Okay, now that makes sense. All right. Now, the third-party payer term or phrase is an umbrella term, and it includes health insurance carriers, like Prudential or Prudential or Aetna or Humana or United, okay? But then we also have third-party payers like Medicare, Medicaid, TRICARE, okay? And Medicare is not actually an insurance company. So that is why we use that third-party payer phrase, umbrella term, to include both the actual insurance companies as well as those other agencies and organizations that actually pay or reimburse for health care to beneficiaries or members, but are not actually insurance companies. Excuse me. So, there are many different types of insurance plans, and you can definitely read about this in your textbook. And the three largest types of insurance plans are health maintenance organizations, usually referred to as HMOs, and then we have preferred provider organizations, usually referred to as PPO, and point of service or POS plans. We also have government plans, as I just mentioned a little bit ago, Medicare, Medicaid, and TRICARE. So I don't know about you, but when I first started learning about this, I had such trouble trying to remember Medicare, Medicaid, which one was which. So I came up with these little hints for you. Medicare, the last two letters are RE, so think about RE as in retired people who are over the age of 65. And that'll help you remember that Medicare is the government program that reimburses for healthcare services provided to people who are over the age of 65 who qualify, as well as people who have a permanent disability, such as blindness, as well as people who have been diagnosed with end-stage renal disease. Medicaid, that was a little trickier. So Medicaid ends in ID, and if you take that ID, you can kind of squeeze it into the word indigent, which means low income, and Medicaid is the government plan that reimburses for health care services on behalf of those who cannot afford to pay for them on their own. And then TRICARE is a government plan that pays for or reimburses for healthcare services to dependents of active duty service members. There were also other types of insurance that end up or participate in reimbursing for certain healthcare services. And those include workers' compensation, disability compensation, as well as liability insurance. This is one of those things, if you remember in Domain 1, we talked about external codes very briefly that explain how and where a patient was when a patient is injured or poisoned. And this is one of the prime reasons why we must include external cause codes when a patient is injured or poisoned, and sometimes ill, because if the patient was injured while at work, we do not send the claim form to their health insurance coverage, we send the claim form to workers' compensation. And if the patient got hurt like while they were shopping at the mall, it is the mall's liability insurance plan that will pay for these healthcare services, not the patient's regular healthcare plan. And disability compensation is going to provide financial support to patients who are permanently disabled. Now, that is not money that is paid to reimburse for services. However, you may be working with a physician who has to qualify a patient for disability compensation, and that's paperwork, and yes, there's a code for that. All right, so now how do they figure out how much money to send in the reimbursement check, okay? We convert documentation into codes, ICD-10-CM, CPT, ICD-10-PCS, and we put that on a claim form. We send that off to a third-party payer, and they send us money, okay? But how is that money being determined? Well, there are three primary methods of compensation. The first is fee-for-service, FFS, and basically that's for every CPT code or procedure code on the claim form, we have already agreed to pay you X amount. And that is determined and released on a published list by January 1st. Usually it's released about October, and it's valid January 1st for third-party payers. And they list every single CPT code or ICD-10-PCS code, and they say, this is how much we're going to pay for CPT code 12345. And this is how much we're going to pay for CPT code 12346. Okay? And on every code. Okay? So the healthcare professional and the coders and billers and the management, healthcare management already knows well in advance how much they're going to be reimbursed. And for every code that's put on there that has been performed, that is justified by a diagnosis code, that's what fee-for-service is, okay? Capitation plans are used most often with health management organizations, or HMOs, in managed care. And that's because managed care, HMOs, use a concept known as the primary care physician, PCP. So every decision about what's going to happen next for this patient is being made by the primary care physician. And primary care physicians are paid by capitation plans from HMOs for every patient that has identified this physician as their primary care physician. That physician receives a fixed amount of money every month, whether the patient has been seen by this physician or not. Now, of course, that money is not for free, for nothing. It includes a specific list of services, like annual physicals and things like that, that are paid for by these monthly things. But if the physician has not seen the patient in 6 months, and this is a patient who is being reimbursed using a capitation plan, that physician is getting that $10 a month every single month. It doesn't matter. Okay? But when that patient finally comes in, certain things provided to that patient will not be extra money. All right? And then we have what's called the Episodic Care Plan of Compensation. And this includes what you should be familiar with by now, which is the concept of reimbursement known as DRGs, which stands for Diagnosis-Related Groups. This essentially is reimbursement based on the diagnosis code as well as other factors. And you can read about those details in your textbook, okay, that basically are reimbursed off of the standard of care. So what that means is, in a simplified form, a patient comes in, hand is swollen, can't move their fingers, very, very painful forearm, patient says they fell. We already know what's going to be happening here, okay? The physician is going to examine the patient, get a little history. They're going to take an x-ray. They're going to confirm that the arm is broken. They're going to put a cast on it. They're going to ask the patient to come back in a few weeks just to do a little follow-up. How you doing? Do you need more pain medication? And then they're going to ask the patient to come back in 6 weeks. They're going to take another x-ray, confirm that the bone is healed perfectly, take the cast off, and say thank you very much, okay? So the concept of episodic care and DRGs is, if we know what's wrong with the patient and we're going to believe that you're using the standard of care to care for this patient, then there's no need to get into all the detail of telling us every little thing you did for this patient. Let's save us both money. We're going to send you one bundle of cash. And that's the episodic care. Being paid in one amount for the entire episode of care based on the diagnoses. It's a little more complicated than that, but that's the general premise. Okay, now patients for the most part, or beneficiaries, or insureds, or whatever you want to call them, also have to do a little cost sharing. And that means that they have to financially participate. In addition to paying monthly premiums to have the insurance to begin with, the patient has to contribute money during the process. And there are 3 methods of payments or patient contributions that need to be made during this process. A copayment is a fixed amount that the patient will pay every time they come to see this facility. So a copayment may be $15 every time they go to see the doctor, but it may be $50 every time they go to the emergency room. But it's always a fixed payment no matter what happened, no matter what kind of treatment they're getting. Coinsurance, however, is a percentage of the entire cost of the episode or the encounter, okay? So coinsurance, and maybe you've seen this in some insurance documentation where they say, oh, this is an 80-20 policy or this is a 70-30 policy. That means the insurance company is going to pay, or the third-party payer is going to pay 80%. The patient is going to pay 20%. Or the third-party payer will pay 70%. The patient will pay 30%. The higher this is one way, the more that the patient agrees to pay is one way to get those monthly premiums down, okay? The deductible is a specific amount that the patient must pay out of pocket before insurance benefits even begin. Excuse me. Now, part of the job in coding and reimbursement and billing and all of this management is that we do need to know, and it's the right thing to know before the patient is even treated or seen, what will that third-party payer actually pay for? Are you covered for this type of service or that type of visit? How do we know besides asking the patient to bring in their policy that they got from the insurance company. Good luck. Who's ever read that or even knows where they put it? Oh, I do. I have a special file. No, I didn't read mine either. Okay, but there are two types of documents that will help you as the coder or the biller or the reimbursement specialist to know what will be paid for. And these are called National Coverage Determinations, or NCDs, and Local Coverage Determinations, LCDs. Now, you know that Medicare and Medicaid are federal programs that are state supported, which means both the federal government and the state governments pay into this reimbursement pool. And in the creation of Medicare and Medicaid, the federal government has also established certain minimum things that will be covered. And those minimum services are expressed in the form of national coverage determinations based on what is being treated, the diagnosis, or sometimes they're based on the procedure, what is being done. And that applies to everybody in all 50 states. But also in this agreement between the federal and the state governments about sharing the costs and the money for Medicaid and Medicare, the states each state individually gets to add on. They're not allowed to do less, but they're allowed to add on additional services that their state program will cover. And that's usually based on, we know our residents need more of this, so we're going to do that for them. And those are expressed in local coverage determinations. And yes, while this was all started, NCDs and LCDs were really kind of started by the federal government for Medicare and Medicaid, you will find that private insurance companies like Prudential and Aetna and Humana and Blue Cross Blue Shield also have documents that do the same thing. So when you know that a patient is going to be, the doctor is recommending this procedure be done, you can then go quickly, and it's an easy search on the website. This patient is covered by Aetna. Go to Aetna's website, put in and do a search for this procedure to find out if this patient's plan will cover them. This is the respectful thing to do. Not only does it make getting your physician or your facility paid easier, but it's respectful to the patient. You wouldn't expect a department store to say, sure, take that jacket. Go ahead, take it home, wear it a few times. And then 3 weeks later, we're going to send you a bill for $2,000 and say, oh no, well, the jacket's $2,000. You didn't know you were going to have to pay $2,000 for that jacket? Well, no, I wouldn't have gotten it if I knew that. Well, it's the same with healthcare. And you know what? You could return a jacket. You can't, go back in and have the doctor put your appendix back in because you couldn't afford to pay for it. Doesn't make sense. All right. Also from the federal government, there are these things called NCCI edits. That stands for the National Correct Coding Initiative, NCCI. And there are two kinds of edits. These are done by computers on every single claim form that is submitted to Medicare and Medicaid. Okay? The first are procedure to procedure. And this has the computer looking for procedure codes that are on the same claim form for the same patient that do not go together. Okay? They cannot or should not be provided to the same patient on the same date of service. And therefore, the computer, if seeing these two procedure codes, CPT codes, on the same claim form for the same patient for the same date of service, will kick that claim. Okay? And then we have medical unlikely edits, MUEs. And these prevent improper services when services are reported in the incorrect units of service. Okay? So, for example, a flu shot is going to be 1 unit of flu vaccine. Okay, that's fine. So you put the code for the administration of the flu injection, and then you put the code for the flu vaccine. You know, the HCPCS level 2 code for the medication. However, in the box where it says number of units instead of 1, you accidentally hit the key twice and you didn't notice it, and you report 11. Well, first of all, that could possibly kill the patient, which is really not good. But the computer will pick that up and pull it as an MUE, because this is medically unlikely that you would give a patient an injection of 11 times the amount of serum that the patient should get. And I'm pretty sure if you were the patient, you wouldn't want that either. Okay, now in domain 1, you remember I mentioned querying the physician, and I'm going to mention it again because it is really important. And there are certain specific ways to write a query. You can't just ask the physician, hey, don't you think this is acute? Okay, there are very specific ways. This slide is more of a reminder to you to make sure that you read about legal queries in your textbook. It's important for you to know. All right. Now, also denial management is a part of what is being covered in this domain. So it's important that you familiarize yourself with some of the most common reasons why a claim may be denied. Now, yes, we just talked about PTP and MUEs, okay? But there are other more common reasons. An error on the claim, such as instead of putting in code 12345, you put in 12579, and there is no such code. Okay, so typos are errors. And remember, a claim form is a legal document. Okay, it may be denied because the patient does not have coverage for that, because somebody didn't look up the LCD or check with eligibility or verification. Or it may be that the diagnosis codes reported did not support medical necessity for that particular procedure. Now, that could also be a typo when entering the diagnosis code, or it could be a diagnosis code was omitted, that there should have been an additional for that particular procedure. But all of these are reasons why claims may be denied. And you see, we mentioned here on the slide ways that they can be prevented, because you should know that also. Okay. You also should understand that a denied claim is not the end of the story. When a claim has been denied, appeals can be very productive, and there are certain ways to appeal a denied claim. And the first begins with the previous slide, which is figuring out why the claim was denied to begin with, which is, by the way, right there on the remittance advice, okay? But a research study was done several years ago that showed 85% of appeals on denied claims were then paid in full. So what does that tell you? All right, if you have any questions, please don't hesitate. Ask in the discussion board or send your instructor an email. We're here to help you.